Hi there, I'm Jim Zirin. Welcome back to Conversations in the Digital Age. With us is an old friend, Stephen Brill. Steve Brill has written a blockbuster of a book. It's entitled America's Bitter Pill: Money, Politics, Backroom Deals, and the Fight to Fix Our Broken Healthcare System. The book is highly relevant. Americans spend about $3.8 trillion annually on healthcare. That's about 16 to 20% of our GDP, 16 to 20% of our income. Steve's book takes us through the history of Obamacare, tells us about its provisions, which most people find a mystery, tells of its successes, and tells of its failures. Steve, we're delighted to have you with us.
Thanks for having me.
Well, congratulations on your book.
Thank
you. You have written other books in the past about wide-ranging subjects, the Teamsters, America post 9/11, and another broken leg of the American program, which is our educational system.
Right.
But what possessed you to write about healthcare?
Well, I like to write about things where I start out actually knowing very little, if not nothing, and have a fresh approach to it. I don't have any preconceived notions. And in the case of healthcare, what I was really curious about was just why it costs so much. During the debates over Obamacare, the real fights and the conversation was, well, who should pay the exorbitant cost of American healthcare? How do we fix insurance or do something so that we can take the burden of this exorbitant cost off of people who can't pay for it? And what I was curious about was, why does it cost so much? Why are we having that conversation and not having the conversation of how come it's so expensive? During that time, there were a couple of books and some magazine articles, very powerful ones, written by people who were facing the dilemma of having a loved one who was terminally ill. And the crisis they faced was, well, should I pay another $500,000 to keep this person alive with chemotherapy for another 6 months or 3 months? Or should I pay another $1 million to keep my elderly loved one alive? What do I do? And my question, beyond that obvious and anguishing ethical question, was, well, why does it cost $1 million? Who's getting that money? So I started my reporting just by attempting to follow the money. I took a half a dozen or more hospital bills and other medical bills and just traced them and decoded them line by line to see, for example, how much the transfusion of a cancer drug cost. And in one case, it was $13,700 just for one dose. And it turns out the hospital, the MD Anderson Cancer Center in Houston, was paying maybe $3,000 and charging $13,700. The drug company, it cost the drug company maybe $200 or $300. So that started to tell the story.
So is this profiteering? I mean, we do see hospital chief executives making seven-figure incomes and drug companies, CEOs making seven-figure incomes. Where's the money going?
Well, as I document in the book, and then I document how Obamacare attempts to and fails to fix this, is that everybody in the healthcare industry, except, ironically, for the doctors and the nurses, is just making way too much money. It's almost as if there's an alternate universe, an alternate economy, where the healthcare economy in this country, which is roughly 1/6 of our overall economy, they didn't get the memo about there being a recession. Incomes continued to soar, prices continued to go up all through the recession, while the rest of us were suffering. And I think the root of that, as I explain in the book, is that it's really not a marketplace. Consumers really can't be consumers with any leverage or any power or any knowledge when it comes to buying health care.
They're completely at the mercy of the healthcare providers, aren't they?
Well, they are. It's sort of a combination of a lot of bad things happening at once. One is they're scared because they're sick. The second is they have no knowledge of what they're being asked to buy. They have no knowledge of whether they actually need it. They have no knowledge of what it's going to cost, or whether this treatment might be more cost effective than that treatment. And the topper is when they get the bill, they have no idea what the bill means.
Well, they have no input into the price, do they?
No input into the price and no input into how it gets paid or how the price is figured out. I mean, hospital executives really can't tell you what things cost. They just know that they mark them up exorbitantly. One of those bills I looked at, for example, there was a $20 charge that the hospital levied for the cuff that goes around your arm when they give you a blood pressure test. There was a $77 charge for a box of gauze pads that you could buy at Walgreens for $2 or $3.
Well, these are what you call charge master prices.
Right.
So this is what the hospital would charge me if I were uninsured.
Right.
Now, if
It's
I
their
am
list
over
price.
65 and I have Medicare, I don't have to pay for any of that, do I?
That stuff goes by the wayside. Medicare pays hospitals under the law their actual cost plus a small percentage of profit to cover, any incidentals and to cover overhead and cover expansion. But for example, if you go to a hospital, the charge master price for one kind of a blood test might be $280. The insurance company, if you have insurance, the private insurance company might pay $140, and Medicare might pay $28.
And before Obamacare, there was Medicaid, so if I was too poor to pay these prices, the government would pay.
If you were covered by Medicaid.
If I were covered.
Yeah, if you were covered.
So what did Obamacare add to the equation, except to bring a lot more customers into the store and more profits for the healthcare
Well, that's
providers?
what it did. Now, that's not a bad thing if you're one of those new customers. The really good thing about Obamacare, and the president deserves great credit for this, is that tens of millions more people who need health care have access to it without having to go bankrupt or without having to be able not to get it and die. So that is tremendously important. That's the good news. The bad news is, as you point out, that what it did was it created all these new customers at the same ridiculous prices that are going to be paid to the so-called nonprofit hospitals, to the drug companies, to the medical device makers, and everybody else.
Now, Obamacare became a political football, a highly partisan focal point,
Right.
with Republicans saying over and over again, this is a government takeover of our healthcare system. Was it a government takeover of our healthcare system?
It's in fact the opposite of a government takeover. If there was a government takeover, you'd have a single-payer system. The government would buy all the health care, as it does for Medicare, and pay hospitals and doctors and drug companies something based on their cost. Obamacare does none of that. It's not a government takeover. Obamacare is the federal treasury stepping in to inject all these new customers with the treasury's dollars into the same private marketplace we've always had, the same abusive private marketplace we've always had. And ironically, Obamacare is a Republican plan. Obamacare is a slightly more conservative version of something Richard Nixon proposed in the 1970s to head off a Ted Kennedy reform proposal. And it's a significantly more conservative version of what Governor Romney did in Massachusetts. So imagine the Democrats'
So new wine in old
surprise.
bottles.
Well, yeah, but imagine the Democrats' surprise when, after years of pushing for much more radical reform, such as a single payer, they basically, in 2009, they throw in the towel and they say, all right, we need to give people coverage. Let's just do it the Republican way. And
that was Romney Care in Massachusetts as well.
So they come up with this Republican plan. So imagine their surprise when the Republicans vehemently oppose it. And that traces back to a scene I recount in the book where the very night of President Obama's inauguration in 2009, Frank Luntz, a Republican pollster and a consultant, who happens to be a good friend of mine, convened a dinner meeting. This is inauguration night, a dinner meeting of top Republican members of the House and Senate and some of their staffs and some of their the political operatives. And the discussion of the meeting was, how do we block the new president? And topic A was, how do we block this new president's plan for health care reform, even though it was a Republican plan.
So they coined the term Obamacare and made it practically into a swear word. I think if you
Yeah.
polled Americans, most would have an unfavorable association with the word Obamacare.
Even many of them who now are benefiting from Obamacare. If you go to Kentucky and you ask people, as I do in the book, what they think of their new health care plan, which has a Kentucky brand name on it, but it is Obamacare, they love it because they have access to health care that they've never had before, and the government is paying for it.
And that
But
plan
if you
was
ask them about Obamacare, they say, oh, we hate that
it's
stuff.
terrible.
We don't
But
like
the Kentucky plan was backed by none other than Mitch McConnell, wasn't it? The senator from
Well,
Kentucky.
when he was running for re-election last fall, the Kentucky plan and program and website is so popular in Kentucky that when he kept being asked about Obamacare, he said, we have to repeal Obamacare, root and branch, but I think we can keep what we have here in Kentucky, which is Obamacare.
Well, and the other thing Luntz did was he said that we'll call this a government takeover, which you point out it was not.
Right,
And
and-
so they said it over and over and over again until everyone believed it.
And he also had a bunch of other good catchphrases. Don't let the government come between you and your doctor. Well, the government isn't between you and your doctor with Obamacare in any way, shape, or form. The entity between you and your doctor continues to be the insurance company that can interrupt your care, that can decide you don't need this drug or you shouldn't get this kind of treatment. That's still there.
Now, you say in the book there are 3 legs to Obamacare. Why don't you
Right.
tell us what those are?
Well, the 3 basic guiding principles and needs are, first, insurance companies are no longer allowed to discriminate against you based on a pre-existing condition. So you automatically can buy insurance.
So the sick can get insurance.
Right. So, the insurance company can't say, well, you're sick or even you have a history of being ill. We don't want to take the risk. You can't get insurance. Or we're going to charge you so much for that insurance that they might as well tell you can't get it because you can't afford it. So there can no longer be any discrimination on the basis of pre-existing conditions. The second leg, however, is that if we're going to do that, then the insurance companies are right. Everybody has to buy insurance because if you could buy your insurance on your way to the hospital, that wouldn't be fair because people would put off buying insurance until they get sick. And the whole idea of insurance, as you know, is you pool the risk. So in any given year, the healthy people who have health insurance are basically subsidizing, that's a dirty word, are subsidizing the sick people who have health insurance. That's why we buy insurance. That's why we buy insurance on our homes, our cars, to spread the risk all around. So that's the second leg. You have to buy insurance. It's called the individual mandate. And the third leg is, well, if we're going to tell you have to buy insurance and you don't have money to buy insurance, we will set up a subsidy system where the government will pay some or all of the premiums that you have to pay.
By the government, you mean the taxpayer?
The taxpayers. Now, that's where the problem comes in because in our country, healthcare is so much more expensive than it is in any other country. In our country, drugs are 40, 50, 60, 80% more than they are in any other country.
Why don't you pause a minute and tell us about that? Is Medicare able to negotiate with drug companies?
No, I mean,
Are
Medicare,
any of us able to negotiate?
No. If a drug company has a patent, which they do, on very important drugs, which we have to salute them for developing, they can charge anything they want, and they do charge anything they want. And
There's one pill that for hepatitis, you point out, was $1,000 a pill.
$1,000 a pill.
And it's an 82 pill program.
Right, 84 pill.
84 pill program.
Who's counting? But $1,000 is actually emblematic of something. It's $1,000. It's not $986.20. It's not $1,011.06. It's $1,000. And what that tells you is they probably decided on their price, as they were walking down the hall on their way to the men's room. They said, screw it, let's just charge $1,000. We can charge anything we want. The next one will charge $2,000.
So are you telling me that I could buy that pill for $500 in Canada or France or
Actually,
England?
it'd be a little less.
A little less?
Yeah.
And so now...
because every other country has some form of price control on prescription drugs.
Well,
now, that doesn't mean the drug companies aren't making a ton of money in Canada and England and France. They sell these drugs just as aggressively. They brag about their profits outside the United States in their annual reports and in their conference calls with stock analysts. happily brag about their profits there. It's just that here, they have doubled the profits.
Now, if I were a drug company, though, my answer to you would be, well, we spend billions of dollars in R&D, research and development, and so we have to cover our costs for that.
Well, that is their answer, and it's a nice answer until you read their financial statements and you see that they spend an average of 10, 12, maybe 15% of their revenue on R&D, much more on marketing and administrative costs. And their profit margins, their gross profit margins are 80, 90%. So there is no justification. And if it were that, then that would mean that they're losing money in all those other countries where they're selling it for so much less.
Let's talk about their marketing program. I turn on morning television. I see Steve Brill being interviewed about his book, and then there's a pause for a commercial announcement from Lipitor or Cialis or something else, which lasts about 30 seconds or 45 seconds. Most of the time, they're warning me about the adverse side effects. That must cost them an enormous amount of money.
It is, but it's worth it because it protects their brand against the inevitable development of generic drugs once their patents wear out. And it makes you ask your doctor about some disease you might not have ever heard of. And now you're being told on television this disease exists, and you say, gee, every once in a while my eyes water too. Maybe I have whatever that thing is they're advertising for watery eyes. And you ask your doctor about it, and then the next time the drug salesman comes in to talk to the doctor says, yeah, some of my patients are talking about that. Maybe I should try it. So it's, oh, and by the way, if you watched television in any other country in the world, I think except for New Zealand, you wouldn't see those ads because they're not allowed.
Someone who really liked your book, Peter Orszag, who was director of Obama's Office of Management and Budget, is critical of your argument about costs because he says we're bending the cost curve, meaning reducing costs, and the Congressional Budget Office said costs were reduced by about 20% last year.
No, that's not what they said.
That's not what they said?
They said the increase in costs was reduced.
The increase was reduced.
Well, there's a big difference. Costs didn't go down. The rate of increase went up, and when they were referring to last year, they were referring to 2013, which was before the Obamacare healthcare exchanges even went into effect. But, I got a chuckle out of, Peter, who otherwise had great praise for the book. So
yes, he did.
I shouldn't be too hard on him, but as the book reveals, the guy fighting in the White House over the fact that there weren't cost controls and writing memos about it, and his staff was writing angry emails to the political side of the White House and the policy side of the White House as the economic staff and the OMB, Office of Management and Budget staff, was Peter Orszag. And Peter Orszag is the one who kept, arguing at meetings, we can't do this. We have to do something about costs. This law is just way too weak. It doesn't do enough. It doesn't do enough, for example, on comparative effectiveness, which is a term of art in this field, meaning that you set up an independent panel of expert doctors who research and report on the comparative effectiveness of various drugs or various medical devices, so that if, for example, drug A costs $1,000 a pill and is directed at curing or stopping a certain kind of cancer, and drug B costs $100 a pill and supposedly does the same thing, if it turns out that drug B is as effective or maybe even more effective than drug A, this panel would report that. And then insurance companies and other decision makers, including Medicare, could decide, you know what, we're only going to let people do drug B, not drug A. Because now the law is that if a drug is FDA approved, it must be available in all insurance. That basically was watered down, so much so that the very same Peter Orszag last year wrote a brutal op-ed piece on Bloomberg complaining that the comparative effectiveness panel is just not doing anything that's useful.
Now, you had your own personal encounter with America's healthcare system. Why don't you briefly tell us about that?
Well,
I mean, it's a good side because you're here, and there's a bad side,
it has a happy ending,
which you can tell us about.
Well, as I was finishing the reporting on the book, and in fact, ironically, the last day of enrollment on the Obamacare exchanges the first year, which would be March 31 of 2014, during a routine checkup with my doctor, he discovered something and did some more tests, and one thing led to another, and within a day I found out that I had something called an aortic aneurysm, which is a bubble that grows on your heart. You have no symptoms. I had worked out the day before. In fact, I'd never missed a day of work for illness in 30 years. So I felt fine. And he said, you need open heart surgery. And I said, what are you kidding? And here I was, someone writing about over-testing and overuse of healthcare, and someone's telling me I need open heart surgery when I feel fine. But it's a good doctor. He was right. And 4 days later, I was on a gurney being wheeled into the operating room at New York Presbyterian, where I had a great surgeon and great care, and they fixed it.
And what was the chargemaster cost, or what would it have been?
Well, the chargemaster cost and all the bills was $190,000.
That includes the surgeon?
Yes, that did include the surgeon.
And what about the anesthesia and everything else?
All in, $190,000.
$190,000. How much did you pay out of pocket?
I just exhausted my deductible, the limit, so I might have paid $10,000. So I had blown through that, by the second night.
So it was covered by insurance?
Yeah, but the interesting thing is hospitals made a big deal when I first started writing about this, that the chargemaster is just fiction. Nobody ever really pays it. Of course, if you don't have insurance, that is exactly what you pay, and that's what the lawyers will sue you for in court. But the insurance companies don't pay it, so it doesn't really mean that much. Well, United Healthcare only got an 8% discount off of my chargemaster because New York Presbyterian is such a good brand, is such a good hospital, and is so big in New York. It's got, it's the merger of New York Hospital with Columbia Presbyterian, plus a lot of other hospitals thrown in, a lot of clinics, a lot of outpatient clinics, a whole bunch of doctors' practices, all under this umbrella, that in essence, if you want to sell insurance in New York, you better have them in your network, and they know it. So their discounts off of the chargemaster are pretty light, and that was the surprising thing.
They don't have the bargaining power, so...
Insurance companies don't have the bargaining power, which is another sort of interesting irony of Obamacare. The president, midway through the fight over Obamacare, suddenly changed his language because his pollsters told him that this would work, and started calling it insurance reform instead of healthcare reform, because everybody hates their insurance company. And one of the aspects I point out in the book about the healthcare industry is that, while we all might hate our insurance company, and usually for good reason, their customer service is terrible, they're not really the bad guys in this story when it comes to exorbitant prices and profits. In fact, they're sort of on our side of the equation.
Well, they're a middleman.
Well, they're paying medical bills just the way we are.
Right. So at prices fixed by the healthcare provider.
Right. So
in any
their
event,
profit margins are actually pretty terrible. They're really terrible. So
we are rapidly running out of time. I'm sorry to tell you, because this is just fascinating, and perhaps you'll come back again and we can talk about this some more. But I have a question for you, Steve Brill. How do we fix our broken healthcare system?
Well, we do something to control the price of drugs. We do something to control the profits and the pricing of so-called nonprofit hospitals. And I lay out a plan in there that's kind of different in terms of how we can do that. But
well, that plan is you want to put hospitals in the insurance business.
Yeah, let hospitals sell their own insurance, since they're so big now anyway. Their own networks are so big. They're typically as big or better than the insurance companies' networks. And they're better brands and they're more accountable. But you only do that with tough regulation of their practices and their pricing.
But that would give them an incentive to keep prices down, because they'd be paying themselves.
They'd be paying themselves.
Well, exactly. That's a wonderful answer. Put hospitals in the insurance business. Steve Brill, thank you so much for coming by.
Thanks for having me.
This has been just wonderful, and thank you for coming by. Please tune in next week for more conversations in the digital age. Visit our website, www.digitalage.org. I am Jim Zirin. All the best, and take care.